DNR, ladies and gentlemen, do not resuscitate, otherwise also referred to as DNAR, do not attempt resuscitation, and more correctly and formally, legally known and referred to as DNA CPR, do not attempt cardiopulmonary resuscitation. The last of these is that which you will come across when completing a form to put in place DNA CPR for any patient that is deemed for the said. What exactly is it? As it says on the tin, DNA CPR, do not attempt cardiopulmonary resuscitation. Why do we do it? When do we do it? How do we do it? So DNA CPR we consider not for patients who are over a certain age. Not at all. It is for patients whom we consider maybe considerably medically compromised. The compromise is from a clinical standpoint, a physiological standpoint. It is imperative that we have a conversation with the patient. If in the event the patient does not have capacity, then we need to have conversation with the next of kin, or if there is a family member, relative, friend, or otherwise whom holds the power of attorney or documentation of a similar statute. In cases where the patient does have capacity, it is strongly advisable that the decision is made with the patient. It is therefore an informed decision. This is not an agreement. It is a decision made by a clinician. And the clinician, in the ideal situation, should be somebody who is either well-versed or otherwise competent in their field. The decision that is made should justify clinically, give clinical justification, a reasoning as to why CPR in the said case would not be of benefit to the patient. It's important that we explore the patient's beliefs, their wishes, their rights, and respect their dignity. And in doing so, we can also explore and explain to the patient, first and foremost, what exactly CPR entails, and then the complications that may occur as a result of CPR. On the back of those complications, what would the patient deem for them acceptable as a quality of life? Now, this aspect should not in any way, shape, or form be influenced by the clinician placing the DNA CPR. It is not for the clinician to suggest, well, if I was you, I would. No, not at all. This is purely to understand and explain to the patient and to understand what the patient deems acceptable as baseline and the quality of life. When I put in place DNR, I will build up to the conversation. I will usually explain to the patient the reason they are here, or the reason for their admission, the reason for their clinical presentation, a working diagnosis. And of course, as you can imagine, the diagnosis needs to be relatively accurate at this stage. And I try to understand through conversation what the patient's baseline is, and then the likelihood, the risk of the patient going into cardiac arrest or respiratory arrest or organ failure, because these are situations where you will need to consider placing a DNR. And then what I need to consider is the likelihood of that CPR actually working. Are we going to acquire ROSC, return of spontaneous circulation? And were we to acquire ROSC on the back of CPR being successful, what then, having had the exploration, having had the conversation with the patient, is then acceptable to that patient as a baseline for their quality of life? The conversation is not easy, it is not light, it is very heavy going, it is very demanding, and demanding not only from a articulation standpoint, but most certainly from a physical, mental standpoint, and also time consuming. You really need to deliver the news or the information in short sentences with sufficient breaks and pauses, so as to allow the patient to come on board and perhaps even somewhat see where the conversation is going. I always explain to the patient DNA CPR simply means what it says on the tin: do not attempt cardiopulmonary resuscitation. I find it is a very common misunderstanding that patients and or their relatives believe that DNA CPR means that we are going to stop treating the patient. That is categorically incorrect. We will continue to treat the patient and address all reversible causes. The only thing we are proposing that we do not do is do the CPR aspect, should the patient go into cardio or respiratory arrest, or if they have multi-organ failure. The youngest patient I have come across as of yet with a DNA CPR in place that was otherwise mobile was a 43-year-old young lady. So age does not come into it. CPR itself is a very brutal procedure. What we learn on first aid courses is perhaps oversimplified and unfortunately couldn't be further from the reality of the situation. I always remind patients, like I say, why the risk of them based on their clinical presentation as a complication of entering cardiac arrest or respiratory arrest. And then the reality of CPR, in that we are going to compress the chest 5 to 6 centimeters at a rate of about 100 beats per minute, 100 compressions per minute. And when we do that in healthy individuals, 40, 50 years of age or otherwise, it is not at all uncommon to be left with a few broken ribs. With patients who are compromised physiologically, medically, clinically, unfortunately their bones for the most part of it are more fragile. So first and foremost we will have more breaks on the ribs, more often than not, on the balance of probabilities. But it's not that what's concerning. The concerning aspect of CPR is actually the fact that the bones are weaker and more fragile. The bones will break differently. They'll be more, it's what we refer to as comminuted. There will be more pieces to each break. It's more of a shattering, perhaps. And when ribs break, some parts will be pointy, some shards, and those pointy bits, as we continue to compress, because what we want to try and do is acquire a return of spontaneous circulation, what will happen is if those ribs are broken, we're not addressing that. We're not going to stop just because we've broken a few ribs. Those shards of ribs, those pointy pieces of ribs, quite likely may well rupture the membranes around the lungs, the parietal membrane, the visceral membrane around the lungs, puncturing the lungs, leading to pneumothorax, air, water, hydro, blood in the areas. As blood is not being pumped to the brain 3 minutes later, and you start to see irreversible brain damage, which will, if CPR was successful, you'll still be left with some permanent irreversible neurological deficit, brain damage. The kidneys, for example, will undergo hypoperfusion, and again, you will be left with some compromise on the kidneys, and hence renal impairment. And the list goes on. So inevitable it is that you'll be left with some multi-organ failure as a result of the CPR. Now with that, and the patient most likely will be on some sort of ventilation in an ICU setting with a view to try and improve their physiological function as we continue to provide care. Is that acceptable to the patient? Is that quality of life acceptable to the patient? Is the patient happy for their loved ones to come and see them in that state? Perhaps knowing full well that they may not recover from this. So DNR is put in place not for anyone and everybody. It is put in place for those individuals who are significantly compromised from a medical standpoint and who may be left with significant complications were the CPR to be effective. So we then, on a balance of probabilities, are kind of perhaps arguing or otherwise saying, well, yes, even if it was successful, you will be left with a significant compromise to your baseline. It is not healthy individuals we consider DNA CPR for, who will otherwise make a good recovery even after the CPR if we have to gain the return of spontaneous circulation. I will follow this video with a couple of cases where 2 or 3 cases perhaps time dependent, and I'll choose varied cases where I've considered where I have put DNR in place and how I went about the approach that I took for the cases. Thank you for watching. Stay tuned.